Kindly take your seats. Good afternoon. We'll start the Squint session, free paper session. Who is the first presenter? Dr. Tushidhar. Tushidhar is there? Not there. Okay. Second presenter, Dr. Subramanya Kota. Yes. The third presenter, Dr. Kiranmai Garg. You please be ready there and no time wasting. 5 minutes means exactly 5 minutes. We'll switch off everything otherwise. Okay, you can start now. Time starts now. Can somebody keep the timing, please? Start now.
My paper is muscle transplantation as an effective primary surgery for large angle horizontal strabismus. Large angle horizontal strabismus is characterized by the angle of more than 60 PD for exo or iso deviation, which presents a challenge in its management. There are conventional techniques such as we have a supramaximal recession or resection, 3 muscle surgery, large bilateral rectus recession, muscle recession with spacers, and hangback or hemi-hangback recession. But all these techniques has some kind of drawbacks. And our study, which is a true muscle transplantation, which offers advantage such as preserving the committance and intraocular handling and post-surgical stability. So purpose of our study to demonstrate the effectiveness of muscle transplantation, which is a primary surgical procedure in case of large angle horizontal strabismus. So our material methods, this is a prospective cross-sectional study. We have done around 25 patients who are having more than 60 PD of ESO or exotropia. Muscle transplantation was a primary procedure for done all these cases. The study was done is in AIO Minto Hospital, Bangalore, and we are included a patient who had a large angle strabismus more than 60 PD, and a patient who had given consent, and excluded patient who are having paralytic squint and previous history of squint surgery, and who had a severe FTT test positive and also poor vision patient. So all motor and sensory evaluation was done before the surgical procedure, and this is the case of a large angle esotropia. So this is surgical demonstration. In the video, in the first stage, we are decided that lateral rectus muscle, which is around 7 mm resection, was decided, and which was secured with the 60 vicryl suture around 7 mm from its incision. This is the first stage. Once we secured the LR muscle at 7 mm, we have to put one more vicryl suture that is exactly at the incision. So this is a little bit tricky. So you have a 2 vicryl suture. You have to be careful. Don't cut the suture in between. After this, we have to do the resect the lateral rectus muscle, and then we have to cut the incision point so that you will get a lateral rectus muscle stump. So this is the cut part of lateral rectus muscle stump, and this is followed by the lateral rectus resection. That is normal lateral rectus muscle which is left over. We have to suture it to the stump part. That is the remaining stump part. And in the next stage, this is the resected lateral rectus muscle which is sutured to its original insertion site. This is a normal procedure. And the third stage, you have to secure the medial rectus muscle. This is just a recession procedure for medial rectus. Put a 60 vicryl suture at the incision of medial rectus and then disinsert the muscle. And the fourth stage, so this is a very tricky procedure where you have to suture the lateral rectus muscle stump to the distal end of medial rectus muscle. So while suturing this one, you have to be very careful so that it should be very tight. So the muscle should not slip during this procedure. Once you secure the lateral rectus stump to the medial rectus, that is the distal part of medial rectus muscle. After this, the last stage of procedure, lateral rectus and medial rectus complex, which is sutured to the sclera, that is 8 mm away from the original insertion in this procedure. This is the last stage. So originally, these are all preoperative patients. So around 12 esotropia patients we have taken. Most all the patients who had around more than 60 PD prism diopter for the distance and near. And there are few residual ESO deviation was left around 10 PD for the distance at the end of 6 months. So follow-up was done for first week and first month and 6 month. And these are the post-op picture. And these are the 13 patient exotropia patient who are more than 60 PD was taken and followed up for 1 week and 1 month and 6 month. And there are few patients who had around residual deviation of exotropia deviation of around 10 PD at the end of 6 months. So all the patients who had underwent above stated primary care procedure were followed up for first week, 1 month and 6 months. And mean preoperative angle was 70 PD in 12 patients with esotropia. Mean age was 32 year. And most of the patients were found to be orthotopic in except 4 patients who had a residual deviation of more than 5 PD at 6 months of follow-up. And main preoperative angle of 66 PD for the exotropia patients. Mean age was 22 years. And preoperative, post-operative angle was left around 4 PD for the 6-month follow-up. And discussion in managing the large angle horizontal strabismus, various technique has been found, but there is a lot of drawback for there, like patient can induce have a severe restriction and incompetence committance following this procedure, and large resection can cause anophthalmos and palpebral fissure narrowing. So conclusion, why our technique has an edge over others? It does not restrict the ocular mobility and avoid resurgery. So it's done on single non-dominant eye and avoids the surgery on multiple muscles, so you don't have to touch the other eye. And there is no co-contraction of the muscle, which results in narrowing of palpebral fissure and other things. So therefore, muscle transfer surgery can be considered as a good alternative primary procedure on non-dominant squinting eye in a very large angle deviation. Thank you.
Otherwise marks will be deducted. We may allow you to continue, but we will deduct the marks. Okay. You have any point?
I just wanted to say that if you do studies on large angles and if you do true muscle transplantation, that is what we used to call it, you should always include what is ocular motility, because large angles can be treated with both eye surgeries. It is not important how to achieve primary position. At least when I started doing it, we used to do it. We still do it only because it gives better motility outcomes rather than doing hang back. You can always do 12 millimeter recession, but there will be ocular motility restriction. So that you have to calculate. Otherwise, primary position.
Yeah, in this procedure, basically the muscle will be secured anterior to the equator. So definitely the limitation of the movements and ocular movement will be much better. Most of the patients we have seen, and all the patients who had a very good ocular motility compared to 3 muscle surgeries, like a large angle recession and all.
Whatever you do, unless the brain.
Good evening, everyone. This is Dr. Kiranmay Garg, and I will be presenting on rare type of congenital fibrosis of extraocular muscles, genotype-phenotype correlation. In the subsequent 5 minutes, let us try to decode the genetic blueprint and understand the phenotypic expression in CFEOM. So, CFEOM is a hereditary, non-progressive, restricted ophthalmoplegia, as the name indicates. It is a monogenic disorder with genetic heterogeneity. Till date, 7 genes have been implicated, which includes KIF21A, FOX2A, TUB3, TUB2B, TUB1A, ECLE1, and COL25A1. Here we report 3 cases of CFEOM studied retrospectively over time, and we tried to correlate the genotype with the phenotype in the following series. All the 3 cases had a pathogenic variant of gene TUB3 at various loci. This gene codes for neuron-specific beta-tubulin, which helps in formation and function of microtubules and further guiding neuronal migration and guidance. This study reports 3 cases of CFEOM with exotropia and restriction of ocular motility to variable extent in different age groups with variable clinical presentation, but a common pathogenic gene variant. Coming to the first case, it was a 26-year-old female with outward deviation and decreased eye movements associated with drooping of upper lid. She had history of ptosis and squint surgery 18 years back, and she also had history of developmental delay and delayed menarche. As we can see in the photograph, she has loss of nasolabial fold and drooping of right corner of mouth. This is a 9-gaze photograph of the patient. She had exotropia of around 100 prism diopters with attempted divergence on down gaze and -3 to -4 grade restriction of ocular movements, vertical more than horizontal. Ocular examination showed that she had right eye best corrected vision of 20/60 with refractive correction of -4 diopter sphere, and left eye BCVA of 20/200 with +3 diopter sphere and -3.5 diopter cylinder at 40 degrees. Anterior segment examination showed anisocoria, and on fundoscopy she had a choroidal neovascular membrane. Then this was the second case who was a 7-year-old male child with developmental delay and drooping of both eye upper lid since birth. As we can see in this photograph, this child also had drooping of right corner of mouth and flat nasolabial fold on right side. He had chin elevation of AHP. The child was not very cooperative to the photographs. He had exotropia of around 50 prism diopters with attempted divergence on down gaze. Restricted motility was seen in all the gazes to variable extent. On ocular examination, both eye had best corrected vision of 20/80 with no significant refractive error. On anterior segment examination, we could see exposure keratitis, and posterior segment examination was unremarkable. Third patient was a developmentally normal 7-month-old child. He had outward deviation of right eye with associated drooping of both eye upper lid, and he had around 45 degrees of exotropia and hypotropia with restricted ocular motility in all the gazes. On ocular examination, the best corrected vision in right eye was 20/470 with +4 diopter of sphere and -1 diopter of cylinder at 80 degrees. And left eye had a best corrected vision of 20/470 with +2.5 diopter sphere and -1 diopter cylinder at 90 degrees. Anterior and posterior segment was unremarkable. So now if we see all the three cases together, they were similar with respect to primary position of the eye being exotropic. All had a AHP. FDT was positive in all the three gazes, and they had a common pathogenic variant of TUB3. So as we have seen this, all the three cases had phenotypic and genetic heterogeneity. And as we saw in the first two cases, there was variable restriction of vertical movements and features of facial nerve palsy. So we can easily confuse it with Mobius syndrome. We need to be mindful of that because in Mobius syndrome, the vertical eye movements will be full and they will be classically esotropia. So genetic tests can help confirm the diagnosis and help anticipate future problems. Thank you.
Conclusion, I mean, how does this study help?
So basically,
Next speaker, if they can come, Dr. Kalyani. Yeah, sorry.
basically this study emphasizes the importance of studying genotype in cases of CFEOM. So one thing is that it can further help in genetic counseling because these cases do have incomplete penetrance and variable expressivity. Second thing is that there's a one gene RYR which is implicated in these patients, and Khan et al. In their study they have also proposed that this gene is associated with malignant hyperthermia. So before taking up such patients for general anesthesia, we need to get the genetic testing done in cases of CFEOM.
What could be the cause of poor vision in your third patient?
It could be due to amblyopia 1, and also he had a refractive error also.
That was not much.
That was not much, but due to ptosis, and also he was not.
There was no posture related to that?
He had AHP also. Could not be captured in the photo. He was not very cooperative, but he had an AHP.
Okay, thank you.
Thank you.
Do you think the refractive error is coincidental or it is probably related to the squinting?
It is usually seen in cases of CFEOM, but it could be due to ptosis also if it is just the cylindric.
No, the refractive error, is it related to the squint or it is coincidental or the squint is related to refractive error? start the timing also. Last time the timing was not right. Please keep the timing properly. You can start now.
Yes, sir. Good afternoon, everybody. My study is about a comparative surgical comparison between two surgical techniques, that is superior oblique tuck with inferior oblique recession versus inferior oblique anterior nasal transposition in cases of congenital superior oblique palsy. I have nil financial disclosure. So even for strabismologists, managing superior oblique palsy is a complex and challenging situation in view of incapacity to examine, especially in cases of children. Then diversity in presentations of SOP. We need to tackle diplopia, AHP, vertical as well as torsional deviations, all in one surgery. So there is, and as such, there is no consensus reached about the best combination of muscles to be operated in a particular case. Yes, yet by von Uden's modification of the NAPS classification, we are either advised to do a superior oblique tuck or a graded inferior oblique recession. But when the hypertropia is like more than or equal to 15 prism diopters, like a large degree of hypertropia, inferior oblique overaction of more than 3 or 4, and a big SO underaction and gross torsion, we have to touch two muscles in this situation. That is, we might have to do superior oblique tuck plus inferior oblique recession. But what if there is a procedure in which we can touch only one muscle and all our agendas can be fulfilled? So we are taking the inferior oblique all the way from its insertion and to taking it beneath the inferior rectus and attaching it at a point 2 by 2 mm nasally and anteriorly to the inferior rectus. So this is the surgical representation of what we actually do. We have disinserted the inferior oblique and then we are taking it all the way beneath the inferior rectus and attaching at a point as shown in the image. So we studied outcomes between Jan 22 to December 24. Group 1 was the traditional IO recessions with SOTUC and group 2 was IOANT. We included only congenital SOPs and we with associated or not associated with horizontal squint. We excluded all the associated vertical squint other than SOPs and previously treated SOPs also. We did a detailed squint examination, but our outcome variables were essentially vertical deviation, improvement in AHP, and a fundus torsion. So this is my Excel sheet. We have also found esotropia with many congenital SOPs bilateral. We found exotropia in only one case. Esotropia and exotropia was managed in the same sitting. And the result are as follows. This is an example of a 35 PD esotropia with grade 3 inferior oblique overaction and an SO underaction. And you can see the post-operatively inferior oblique underaction has collapsed nicely, and so is the superior oblique underaction. So why are we having this basically, and what is the physiological funda behind inferior oblique anteronasal transposition? So this is how the inferior oblique direction is post-graded IO recession, and this is how along the neurovascular bundle the position of IO after IOANT. So basically we are turning an extorter into an intorter and an elevator into a depressor. So we can see a very good collapsed inferior oblique overaction and an SO underaction, and also the gross excyclotorsion can be eliminated with this procedure. We followed up the patients at the statistical analysis was done at 6 months, and we found that vertical deviation, IO overaction, SO underaction, all were comparable in both the groups. The results were comparable. Yet we found what is significantly we found in the study is the time required in IONT was much lesser than the second group, as we are touching only one muscle in this group. So about the intraoperative complications, we had one patient with consecutive exotropia. In IOANT group, maybe we placed the inferior oblique 3 mm nasal in this situation, which led to exotropia, which was taken care by the prism. So what was already known as large angle superior oblique palsy muscle needs 2 muscle surgery, but it can, and there is also a risk of anti-elevation syndrome and the risk of recurrence and residual IO overaction as well. But an IO anterior nasal transposition had been studied earlier by the many doyens in strabismology. But what we are trying to tell from this study is it can be done in congenital SOP also. It is easy, safe, less time consuming and equally effective to it, and very effective in tackling large angle inferior oblique overaction, large hypertropias, torsion, and AHPs as well. Thank you.
One question.
Yes,
Have
ma'am.
you done randomization of the patients while choosing in which group those patients?
Yes,
will
ma'am.
be?
It was totally randomized, and we purposefully chose only the patients in which we had a large angle of hypertropia. So
Amit
that
Mohan.
That I know.
yes,
Randomization
Yeah,
of
yeah.
procedure while choosing the groups.
yes, ma'am. That procedure was totally randomized between congenital SOPs.
Okay.
How did you randomize? Generated in the computer or you generated it manually? How did you randomize?
So we generated it manually only.
So you, that was double blind. You did not know what the patient had. Amit,
Yeah.
नहीं वो नाम है ना? आजमगढ़ में, ठीक है. Did you do FDT in all the?
Yes, sir. Pre-surgically, FDT was done in all the patients. Yes, sir.
You felt that probably was very high.
Yes, only those cases.
Did you get any MRI done to see whether the supraoblique classic there is a congenital supraoblique patients who
Yeah.
have a very thin supraoblique? Did you find any of the patients where you planning to do a TAC and you felt that supraoblique was actually missing and you could not do it? There was no such patient.
No, sir. This particular thing we did not find in any of the cases. Thank you, sir.
Good afternoon, everyone. My paper on nasal transposition of split lateral rectus muscle with medial rectus resection in third nerve palsy. As we all know that third nerve palsy is very difficult strabismus to manage surgically. Surgical management options include lateral rectus deactivation or vital fixation of medial rectus, superior oblique transposition at medial rectus muscle, and LR muscle transposition supranasal. The Kaufman has first described the isolating and splitting the lateral rectus muscle and transposing the superior and inferior halves to a retroequatorial location to for the management of third nerve palsy. Later, Gokigit et al. Suggested modification of this technique by transposing the superior and inferior halves of the split LR muscle 2 mm posterior to the superior and inferior border of the MR muscles. The purpose of our study is to evaluate the post-operative ocular alignment in patients who underwent for nasal transposition of split lateral rectus muscles for third nerve palsy. A retrospective review of the medical record of patients treated for third nerve palsy with nasal transposition of split LR was performed after institutional review board approval. Informed written consent was taken from the patient to use their photographs. The initial and final ocular alignment, post-operative ocular motility, and complication were noted. Surgical success was defined as post-operative alignment within 10 prism diopter of orthotropia in primary position by Krimsky test. The surgical technique what we have followed, radial conjunctival incision was placed in all 4 quadrants of the operative eye. The LR muscle was isolated and separated from the attachments to the surrounding tendons, pulleys, and inferior oblique muscles. The upper and lower half of LR muscle was secured at the insertion with 2 separate double-armed Becquerel sutures, and the muscle was then detached and split in half longitudinally as much posterior as possible. And muscle hook was placed within the superior nasal conjunctival incision and passed laterally under the superior oblique and superior rectus muscle, and the upper LR suture was passed through the opening in the gas hook, and hook was retracted to transpose the suture at the superior pole of the MR muscles. Similarly, the inferior oblique muscle was exposed and through the inferotemporal conjunctival incision, and the upper half of the lower half of the LR muscle was passed through the inferior oblique and inferior rectus muscle, and this was transported at the lower pole of the medial rectus muscles. And MR muscle was also resected about 6.5 mm in each cases. The total 4 patients, 2 male and 2 female, were included in our study. Only in 3 patients, desired procedure was successfully completed. Mean preoperative deviation was 85 PD exotropia. All 3 patients were within 5 PD of orthotropia post-operatively. Eye movement were limited in all patients post-operatively, and no other complication was noted in our series. The procedure not completed in 1 case because of extensive fibrosis of LR muscles, which prevented splitting and transposition beyond the temporal aspects of the vertical rectus muscle. A successful outcome was achieved in all 3 patients in whom the procedure was completed. Average follow-up was 8.3 months, and the 1 patient had preoperative vertical misalignment that was not resolved with the surgery. This is the case detail in the age group 21 years. The first patient is 90 PDXT, which was This was the case of 90 PDXT, which, which was ortho post-operatively. However, the movements were restricted. This was the same patients in the primary position. This was the second patient in which the patient has large angle exotropia with the hypo. The exotropia is resolved with the surgery, but the hypo, 5 PD hypo was present post-operatively. This was another case of the complete third nerve palsy. The child is ortho post-operatively. So in discussion, the nasal transposition of the LR muscle to treat strabismus due to third nerve palsy was first described by Taylor as a transposition of the entire muscle to the superior nasal globe. The procedure reduce his patient exotropia by 40 to 50 prism diopter. Kaufman addressed potential problems with induced torsion and vertical deviation by splitting the LR muscle and transposing the superior and inferior halves to a region 20 mm posterior to the limbus and posterior to the superior and inferior nasal vortex vein. In an effort to obtain further reduction of the horizontal deviation, Goki modified this technique, bringing the superior and inferior halves of the LR muscle anterior to the vortex vein and approximately 2 mm from superior and inferior edge of the muscle, MR muscles. Their innovation of placing the muscle halves pre-equatorial greatly improved the effectiveness of this concept. In our technique, we have combined this technique with subsequent MR strengthening procedure, suggesting that this is more likely to give long-term benefit because of mechanical forces by the resecting the MR muscles, as well as there is no opposing forces from the LR. So to conclude, the nasal transposition of the split LR muscle for treatment of strabismus associated with third nerve palsy offer excellent horizontal alignment in primary position. We advise caution when considering the procedure for patients with extreme LR muscle contracture. It's better to abandon this procedure in that cases. Thank you.
Procedure has already been described. Yes, well known.
Yes, sir.
So, how should I mark your originality for your paper?
Sir?
He has done it for the first time, sir.
First time.
It is there in the literature. He is presenting his own data, sir. You mark as you want to mark.
No, I'm just joking. See, they've asked us mark the paper based on the originality. So I asked you a question. Has it been described? Okay, never mind. Well done.
These are all very difficult, sir. Congratulations. Did you cut the infraoblique and supraoblique also, tenotomy or myectomy?
No, sir.
You did not do it. Lucky for you, you got away with it without having any choroidal effusion or anything.
No, in all three cases there is no
There was
choroidal
no choroidal
effusion.
effusion. Yes.
Okay.
Yes, sir, thank you.
Time, we have started already time. Yeah. Good evening, I will be presenting a novel approach of triple pass at double augmentation of NAP procedure in double elevator palsy. Double elevator palsy, precisely known as MED, is defined as limitation of elevation of affected eye in both abduction and adduction, with normal duction in all other cases, and often there is a mild residual hypotropia even after NAP and IR recession. So augmented NAP procedure utilizes NAP procedure combined with posterior fixation Foster suture or sutures on the horizontal recti to increase its effect. So to enhance the effect of NAP, we did double augmentation by combination of intermuscular augmentation along with a scleral pass, which creates another augmentation and ensures vector created by this transposition are more effective along superior rectus vector forces and postulated shift of muscle pulleys. So the aim of study was to report and describe the effect of double augmentation of NAP procedure in double elevator palsy in series of 5 patients, and whenever angle is more than 35 prism diopter of hypertropia, augmented NAP procedures are usually advocated. Horizontal rectus transposition, as we know, is always more powerful than vertical rectus, and studies have been reported where intermuscular augmentation and Foster suture augmentation not only improve the abduction limitation but also enhances the binocular field in 6th nerve palsy and Duane retraction syndrome. So the similar concept was used in these studies. In this series, all the cases had large hypertrophy of more than 40 prism diopter and with limitation of elevation in adduction and abduction. And in this, lateral rectus was transposed near the superior rectus, and after transposing at 8 mm, 1/3 of the lateral rectus fibers were taken with the help of 5-0 non-absorbable ethibond suture, and then passed at the sclera 13 millimeter from the limbus, and then again 1/3 fibers of the superior rectus were taken, incorporating 1/3 of the fibers, and thus the triple pass along with both the muscle augmentation and scleral pass. Similarly, in the medial side, medial rectus was also transposed, but it was transposed after resection of 3.5 to 4 mm, and 1/3 medial rectus fibers were taken, a scleral pass at 13 millimeter, and again 1/3 fibers of superior rectus were taken. Now, in all the cases, FDT was done to ensure no inferior restriction. So these are the 9-gaze photographs of case 1 and 2, in which we can see in first case there is right large hypertropia, and post-op there was nice improvement in the elevation of the hypertropic eye, and in second image there is improvement in not only in hypertropia of the left eye, but also improvement in limitation in adduction and abduction. Third patient was a pediatric patient, and in this patient also there was improvement in adduction and abduction limitation after double augmentation. Patient 4 and 5 didn't consent for their photograph sharing. So coming to result, all the 5 cases were male, age ranging from 8 to 28 years, with left eye involvement in 3 cases. Fifth case has additional inverse Marcus gun jaw winking. All cases had 45 to 50 prism diopter, and there was residual of 5 to 10 in 4 cases. Only in 1 case had 15 prism residual hypertropia, and in all cases maintained this position at 3 months also. So this is the figure showing where medial rectus resection was done in all cases with 3.5 mm MR marked, and this figure shows both the lateral rectus and medial rectus transposed near the superior rectus with augmentation done at 8 mm. So limitation of our study is that it is a non-comparative study. It is only a case series. A prospective study comparing traditional NAP versus this double augmented NAP could give us more definitive result. So there are several studies in which authors have compared augmented NAP procedure with superior posterior fixation suture, but not in combination with this. Only one study by Acker et al. They did this augmentation NAP procedure along with intermuscular augmentation, and in our series we have additional resection of the medial rectus muscle. So to conclude, this procedure of double augmentation with intermuscular augmentation with scleral suture helps in decreasing the large angle hypertropia and improvement in elevation in abduction and adduction. So thank you for patient hearing.
So I presume that FDT was negative in all the patients.
Yeah,
So you did only 2 muscles, medial rectus and
and
lateral
lateral rectus. Yeah.
So I think when you do such a strong and incompetent, because I would call it as an incompetent procedure,
Yeah.
it is not very important to see how much improvement in elevation it has made. In fact, there are multiple studies which report that after a few years, and I have seen in my own patients also, that after a few years the eye actually starts drifting even more upwards. So
Yeah,
I would
so
be more curious to know.
the long-term results can be variable because
No, I would be more curious to not only know the long-term results, but because you have already presented your results in 5 patients, so we have to discuss right now this only. So I would be more curious to know what was the point in down gaze and how much binocular field of vision actually improved. Because if we lose out on the down gaze, and these patients are very notorious in down gaze, because the moment you pull them up a lot, they actually go blank in down gaze. They lose their, whatever useful binocular vision they had in
all
down
of the
gaze.
patient had nil BSV. Like
Nil?
none of the patient had.
I was
BSV
talking
present.
about the movement in the inferior gaze.
So inferior movement it doesn't.
But
it
in the
was not.
photograph I could see the inferior gaze was affected. There was no effect in the inferior gaze.
No, we have not checked the inferior field as such inferior field, but there was no, you are saying in all the patient the elevation improved, but there
The
was
depression did not get restricted.
only in one patient, no, depression didn't get restricted.
Oh, that's amazing. That's very good.
The monocular elevation deficiency is primarily
Yeah, so it is always included, that's why it is included in congenital cranial dysnervation syndrome.
Is it a motility disorder or is it strabismus? Strabismus meaning is there a misalignment in primary gaze?
Yeah.
There may not be. So in such a situation where there is no squint but it operating on the muscle, what are you gaining? Nothing. You are worsening the primary situation, primary case.
Angle, large angle. It is 45 to 50 prism diopter and along with FDT negative where we cannot do inferior rectus recession. Large hypertrophy. Not the-
So what were the challenges of doing resection along with the
Triple pass.
transfusion? So what
Yeah,
was the
yeah.
challenge?
So yeah, that's why in pediatric case, like we were very worrisome, like doing 3.5 mm dissection should not create the overcorrection. But as all the cases had needle stereopsis and even one case was amblyopic, so we don't know, like if in patient who are having BSV, they can have down gaze diplopia also.
Thank you.
Good evening, everyone. My name is Dr. Pooja, and my topic is the impact of part-time occlusion therapy on fine motor skills in unilateral moderate amblyopes patient. It's not working. It's not working. As we know, reduced stereopsis is the most common visual deficit associated with amblyopia, which results in poor fine motor performances. Fine motor skills in amblyopic children are observed to be suboptimal as compared to children of normal age group. As visual acuity and stereo acuity is reported to improve significantly after amblyopia therapy, fine motor skills are also expected to improve. The aim and primary objective of the study is to evaluate the impact of part-time occlusion therapy on fine motor skills in children aged 3 to 10 years with unilateral moderate amblyopia at 4 months as compared to baseline, which is measured by Bender Visual Motor Gestalt Test. And other secondary objectives are to explore the changes in the performances of the study participants in following motor tasks as compared to the baseline after 4 months of the part-time occlusion therapy. These fine motor skills are Developmental Coordination Disorder Questionnaire, Ray-Ostrich Complex Figure Test, Jepson-Taylor Hand Function Test, and Bender Visual Motor Gestalt Test. Other secondary objectives are to determine any possible association between different types of amblyopia and improvement in fine motor skills. Baseline visual acuity and improvement in fine motor skills, types of refractive error and improvement in fine motor skills. It is an hospital-based prospective interventional study conducted between April 23 to April 24. The sample size was 35 and the patient was patient visiting to ophthalmology and pediatric OPD of AIMS Rishikesh. The inclusion criteria are consenting patient, age range of 3 to 10 years, children with moderate amblyopia with no history of previous treatment for amblyopia, compliant to best refractive correction for at least last 12 weeks, and patient should be orthophoric. Exclusion criteria are mild and severe amblyopia, any coexisting macular, retinal, or corneal disease reducing visual acuity, significant cognitive impairment, history of any brain or neurological disorders, craniofacial abnormalities, history of any blunt trauma, penetrating trauma to the eye, history of any prior intraocular surgery except the cataract surgery, myopia with a spherical equivalent of -6 diopter, and known skin reaction to patch or bandage adhesives. This is a schematic diagram showing the study flow. First, written informed consent was taken, then relative history taking was done. Basic ophthalmological evaluation, including best corrective visual acuity, refraction, intraocular pressure, anterior segment, and fundus examination was done. Along with baseline binocular test, stereopsis was conducted with baseline fine motor skills. Assessment was done. Then 2 hours of part-time occlusion therapy with 1 hour of near work was prescribed to the patient. And assessment of all these fine motor skills, including stereopsis and binocular function test, was done at first and 4th month of the follow-up. These results were used for our study and analysis. This is the Bender Visual Motor Gestalt Test. This consists of 9 index cards, and the score ranging was 0 to 13 were given to the subjects, while higher score indicates the poor performances. This is the Ray-Ostrich Complex Figure Test. The participants were asked to copy this figure, and the score ranging was 0 to 36 was given, while lower score indicates the poor performances. Jepson-Taylor Hand Function Test. The patients were given 7 items, which include writing, turning the cards, picking up small common objects, simulated feeding, stacking checkers, picking up large light objects, and picking up large heavy objects. The results were measured by time taken to accomplish each task. More the time taken as compared to age match control indicate poor performances. This is the DCDQ, Developmental Coordination Disorder Questionnaire. This questionnaire is developed for parents, as parents know their child the best and can reliably report developmental problems. This consisted of 15 items, which are grouped into 3 distinct factors, which includes control during movement, fine motor and handwriting, and general coordination. These are the results showing the improvement in vision at 2nd month and 4th month of the therapy. This is the Rando test in Titmus stereo acuity test showing the improvement after the therapy. And similarly, Worth dot and Bagolini striated glasses test showing the improvement after the therapy. These are all fine motor, bar diagrams showing the fine motor skills improvement after the 4 month of the therapy. These are the significant improvement we found after the therapy. So we found significant improvement in fine motor skills at 4 months of the amblyopia therapy. And we also found anisometric amblyopes demonstrated significantly better improvement in BCVA at 4 months and ray ostrich complex figure at the 2nd and 4 months of the therapy. There was no significant association observed between fine motor skills and etiology of amblyopia. To conclude, a positive impact of amblyopia therapy in the form of 2 hours of part-time occlusion therapy with 1 hour of near visual exercises on best corrected visual acuity, stereopsis, and fine motor skills was found. Reduced stereo acuity has been shown to have correlations with poor performances in fine motor skills as compared to reduced visual acuity alone. Thank you.
Brain.
Sir, frontal lobe.
Frontal lobe where? Right, the whole area is frontal lobe. But there is a reason I am asking you this question. Where is the hand area situated in the brain?
Area number 4, sir.
Huh?
Area number 4.
No, no. It's situated close to the frontal eye field area. It's 1 millimeter below and anterior to the frontal eye field area. Now, stimulating the frontal eye field area can stimulate the hand area. Patching, how does it stimulate the frontal eye field area?
Sir, patching improves the vision and stereopsis.
No.
So
How does the patching stimulate the hand area? It doesn't do anything.
See, we all know that amblyopia therapy, better stereo acuity helps in motor skills, fine motor skills. This is all, I mean, this is all there.
Next is
So-
Ankita. Ready?
What does your study tell us?
sir, my studies tells that if vision improves with part-time occlusion therapy and stereo acuity also improves, so fine motor skills should also improve.
They would improve because stereo acuity has improved. If I close one of my eyes, my fine motor skills are not going to get good. I mean, this is all there. So I think you should publish it. See, that is how people publish. When you read articles, you feel that there is nothing new in this. So you better publish it like this, that whether these questionnaires can replace stereo acuity, and then it is something new that you have come up with. Right now you are talking about stereopsis has improved, and this fine motor this is known. Whether these fine motor skills improvement can also mimic an improvement of stereo acuity, and so you don't need to check stereo acuity, rather you check fine motor skills.
Okay, sir.
So you can do it. I mean, I don't know whether they will publish it or not, but this is another way of looking at it. Good, very good.
Why you have chosen 3 hours of patching? The age range was different.
Yes, ma'am.
Yeah.
But the recent studies have shown that part-time occlusion is equivalent to full-time
Yeah,
occlusion
that I
therapy.
know, but 3 hours were
2 hours, ma'am. 2 hours. These are my patients are moderate amblyopes, so I have chosen 2 hours of part-time occlusion therapy.
okay.
Thank you.
Ankita, Dr. Ankita is not there? Okay.
Dr. Harshvardhan.
Harshvardhan?
This was a good study. I wanted to listen to that intersegmentosity of lid. Anyway, Dr. Harshvardhan? Dr. Harshvardhan? Fine. Dr. Kirti? Great.
Good evening, everyone. I'm presenting a paper on surgical outcomes in acute acquired comitant esotropia. This is a multicentric study studied in 3 different centers. Acute acquired comitant esotropia, or ACE, is a relatively rare condition. It has a sudden onset of comitant esotropia with diplopia. The exact cause is unclear in most cases. There has been a recent rise in the cases of ACE after COVID-19, especially due to excessive near work like prolonged gadget use. For ACE, different treatment options have been suggested, like botulinum toxin or surgical intervention for good prognosis of binocular function. My objective is to assess the motor and sensory outcomes of surgical correction in ACE. So this is a multicentric study. It's a retrospective observational study conducted over 18 months, and my sample size is 22. Inclusion criteria includes all cases which is diagnosed and operated for ACE with or without diplopia from Jan 2023 to June 2024. Exclusion criteria includes if for all cases MRI brain was done, and if there was a neurological lesion, those cases were excluded. Any systemic diseases like myasthenia graves, these were excluded. Past history of strabismus or strabismus surgery, or if there's an accommodative component present, we have excluded those cases. Methodology: records of patients diagnosed with ACE who have undergone surgery in that time period at 3 different centers were reviewed, and we have studied all these factors which I'll be explaining. So what we found was the age when squint was first noticed was as less as 3 years of age to 31 years. So both children and adults have presented with acute sudden onset of esotropia plus or minus diplopia. And age at presentation was 4 to 33 years with a mean of around 8 years of age. First consultation was after how long of onset? It was as early as the very same day of onset of esotropia to as late as 30 months. None of them had any history of strabismus trauma or any patching history. All of these cases had normal external ocular examination, anterior posterior segments, full extraocular movements, normal MRI brain. 45% were emmetropic, remaining had either minimal myopia or astigmatism, and all had a best corrected visual acuity of 6/6. Precipitating factors, we found that many of them, most of them did not have any precipitating factors, but many of them gave history of increased screen time of above 5 hours per day. Some of them gave history of fever, some gave history of irregular glasses use. At the time of surgery, age was around 4 to 33 years. After how long of onset was surgery done? Surgery was done, basically surgery was planned as soon as stable measurements, consecutive stable measurements were available for the patients. The type of surgery in 2 centers, a pure recession resection in one eye was performed. In one center, bimedial recession with or without lateral rectus resection was done. No intraoperative or postoperative complications were there. No reoperations were there. Now coming to the postoperative results. Postoperative, we have seen results for up to 6 months. All out of 22 patients, 20 patients were orthophoric, and on cover test, we can see that out of 22, 19 patients had just esophoria at 6 months. So this suggests excellent motor outcome. On measurement of squint, preoperatively was about 40 to 50 prism diopters, and postoperatively that was reduced to 5 to 10 prism diopters. So this is suggesting a very good motor outcome. Coming to the sensory outcomes, preoperatively, out of 22 patients, 10 of them had suppression and 12 of them had diplopia. Nobody had fusion. Post-operatively, you can see that nobody had diplopia. 11 of them had fusion and 11 had suppression. And pre-operatively, the 10 out of the 10 people who had suppression, 4 had developed fusion, and out of the 12 who had diplopia, 7 had developed fusion. And coming to stereopsis, 13 had no stereopsis pre-operatively, whereas post-operatively 13 recovered very good stereopsis. So we are saying we got very good sensory outcomes. So the conclusion is that it's a comparatively rare type of squint with limited large-scale studies. There's a recent surge in ACE that has been noted in all the centers. Surgical correction is not only a permanent management modality for ACE, but also it provides very good motor as well as sensory outcomes. Sensory outcomes were as good as the motor outcomes, and the post-operative stereopsis is expected to recover favorably and may take longer. Thank you.
AAC is not relatively rare. Nowadays it has become fairly common.
Yes, sir.
Don't say relatively rare.
Yes, sir.
So particularly after COVID, I am seeing a lot of cases of not only AAC but other types of squints also.
Yes, sir.
We don't know. See, the primary problem in any squint is not the muscle. The primary problem is in the brain. That we have to remember.
Yes, sir.
What we are trying to do is operating, as somebody said, the operating on the bones for the neurological problem is what we are doing. Orthopedic solution for neurological problem. Okay, good, well done.
Thank you.
So good evening everyone. So this study is about the surgical outcomes of true muscle transplantation in large angle infantile esotropia. So as we know that large angle strabismus is often challenging and demands a series of surgery to achieve a satisfactory alignment, and the surgery involves multiple muscle and often necessitate to operate in the both eyes. True muscle transplant is a novel technique which basically involves transplantation of the resected stump of the tendon of lateral rectus and anastomosing it with the medial rectus. So what is the advantage by doing so? So the fact that the actual insertion of the muscle remains anterior to the functional equator, and yet the elongated length of the muscle results in good primary position alignment without any lateral incompetence. So this study reports the surgical outcomes of the TMT in large angle infantile esotropia, and it was a retrospective study which include all patients with infantile esotropia of more than 60 prism diopters, and was managed primarily as a TMT as a primary surgery. And those patients who are who had a minimal duration of follow-up less than 3 months and who underwent resurgery were excluded. So the primary outcomes we studied were the ocular alignment in primary gaze and its stability at 6 weeks and the last follow-up. And the secondary outcomes includes the lateral incompetence, the change in the palpebral fissure height, and the stereopsis. The correction factor, the total correction was calculated as a preoperative deviation divided, subtracted by the deviation at 6 months post-operative, and the magnitude of correction in prism diopters obtained per mm of transplantation was calculated as total correction subtracted by the correction due to the muscle recession and resection divided by the length of the transplanted segment. So the results, you can see here that the mean deviation change, the pre-operative deviation, which was 69.55, was reduced to about 3 prism diopters at the 6 weeks, and then it was stable at the final follow-up. And in the picture here, you can see that this kid has a 75 prism diopters of esotropia, the 2 weeks alignment, and then the final 1 year alignment. You can see the stability and the palpebral fissure height is not changed. So the we did the motility analysis as well. So in here we can see that the abduction limitation, which was like post-operatively in majority of the cases, it was just grade 1, and that too in the very large ET, like 95 prism diopters. And similarly, the palpebral fissure height, the pre and post operative was statistically significant, and there was no limitation on the duction, and the palpebral fissure height was also the same. So these are the surgical details of each individual cases, and the average correction ratio which we got was 2.94 prism diopters. And to summarize, the mean resection which we did for the lateral rectus was in the range of 9 to 12, and the medial rectus ranged from 5 to 6 and the total segment which was like transplanted ranged from 5.5 to 8 So there's a limited literature available in the long-term stability of the angle of deviation, and it was already reported by Jethani et al., and they have seen in the largest series of 22 cases of esotropia, and also the result correlates with the in terms of the success rate with Dr. Amitava et al. And there is a slight variation in the outcome, and that can be attributed to the difference in the patient selection, the surgical technique might be, and the etiology of the esotropia and follow-up duration. So the average correction per mm which we got was 2.94, whereas Amitava et al. Reported a correction factor of 3.9 prism diopters. So to conclude, true muscle transplantation emerges as a promising surgical alternative to in managing the large angle infantile esotropia, and this technique offers significant advantage, including in terms of alignment, in terms of the incompetence, and the preserving the palpebral fissure symmetry. And with further refinement and standardizing the surgical guidelines, we can use this as a potential the mainstay approach for the complex strabismus and the large angle correction, large angle strabismus. Thank you.
Just a small, I would just tell you. Amitava sir actually had done for exotropia, and that is the reason he has got more than what we or you got, because all our patients and your patients are in esotropia, whereas his patients were primary amblyopic patients.
Yeah.
And so probably the lateral rectus was tight, and so when they did surgery, they got better, rather more result than what we could get.
Thank you. Yeah, thank you.
Good evening. Today I would be presenting a modified superior oblique suture spacer technique for correction of the A pattern strabismus. As we all know that pattern strabismus are a type of strabismus where horizontal deviation changes during the excursion of the eye from the up gaze to down gaze, common being A and V pattern, and when eye converges from the down gaze to up gaze, it is known as A pattern and considered significant when it is more than 10 prism diopter. The pathophysiology is multifactorial, but oblique muscle dysfunction is considered to be important. Superior oblique overaction is often related with the A pattern strabismus, and thus weakening procedure for the superior oblique helps in correction of the A pattern. So we retrospectively studied all the patients who underwent unilateral or bilateral modified superior oblique suture spacer for A pattern strabismus. Patients who underwent horizontal muscle surgery along with the procedure were included, and those who had undergone the oblique muscle surgery or simultaneous vertical rectus muscle surgery were excluded. A complete orthoptic evaluation, the ocular motility and fundus torsion was noted, and the follow-up was conducted at the 6 weeks. The superior oblique overaction was graded as shown in the image. Exaggerated traction test was performed pre and post-operatively under general anesthesia, and the length of the suture spacing to be done was determined by the amount of A pattern. So here I will briefly describe the technique. All the surgery were performed by Dr. Shelja Tibrewal. And so after hooking the superior rectus muscle, superior oblique was isolated from temporal aspect, and then it was brought to the nasal side. Superior oblique tendon was secured at the two ends. The proximal and the side interlocking sutures were taken, and both the cut end of the sutures were brought from the distal end 2 to 3 millimeter away. So after bringing it from the center of the distal end, the superior oblique tendon was cut between the two ends, and then the desired amount of the lengthening was measured, and the adjustable bow tie note was taken, and then after that the exaggerated traction test was repeated intraoperatively, and based on the traction test the amount of lengthening was again measured and adjusted intraoperatively. After achieving the desired amount of the lengthening, the bow tie note was finalized, and the additional securing bites were taken to avoid the late slippage of the note. So total 8 patients were studied. The median age was 15 years. Bilateral superior oblique overaction was observed in 7 patients and unilateral in 1. Preoperative superior oblique overaction ranged from 1+ to 3+, and the median right eye superior oblique overaction was 2+, whereas in the left eye it was 3+. The median A pattern was 22.5 PD. So post-operatively, out of 8 patients, all the 7 patients had complete collapse of the A pattern. The remaining 1 patient showed reduction in the A pattern with the residual pattern of the 12 PD. The median collapse in A pattern was 18 PD. Post-operatively at 6 weeks, there was significant reduction of the horizontal deviation for the distance and near, and also the reduction in the vertical deviation. So though there was a significant collapse of the A pattern, all patients except one had the persistent superior oblique overaction, to the superior oblique overaction reduced in all cases. As we all know that the etiology of the pattern strabismus is multifactorial, and the primary superior oblique overaction is related to the A pattern strabismus. The weakening procedure options available are the tenotomy, posterior tenectomy, simple recession of the superior oblique, and the right silicone expander. Out of all this, only two can be graded, that is a spacer, either silicone or sutures, and the split lengthening of the superior oblique tendon. Advantage of this superior oblique suture spacer is that it is a simple procedure. Any amount of the lengthening is possible. It can be graded intraoperatively based on the traction test. So in our study, we found the results which are comparable to the previous study described by the Sir et al. And in our study, we also found the median collapse of the A pattern of the 18 PD. The median reduction in the superior oblique overaction was +1 in both the eyes, and none of our patient had overcorrection or recurrence after the surgery. The limitation is that it has a small sample size, a retrospective nature, and a dose-response relationship cannot be derived because of the technique of the small sample size. So this is a pilot study, but it is offering the simplicity, adaptability, and it is repeatable. So thus can be studied further with the patients. Thank you.
How many fibers are there in superior oblique?
So the posterior fibers and
Totally, how many fibers are there in superior oblique? Approximately.
numbers not.
6,000 and odd. The two threads you leave
Yes, sir.
separating, do they do the function of these 6,000 fibers?
No, sir, not 6,000.
Huh?
Not the 6,000.
No, you didn't understand my question. What I'm asking is the 6,000 and odd fibers of superior oblique which span out like this.
Yes, sir.
The anterior 1/3 is intorta.
Yes, sir. And
The
posterior is
middle 1/3 of the fibers, they do the function of depression. And the posterior 1/3 of the superior oblique fibers.
abductor.
Okay. Now what you have done is you have left two like this.
Yes, sir.
Two sutures,
Yes,
and
sir.
they take care of the function of all the muscle fibers of superior oblique.
Yes,
You
sir.
expect them to. Do you?
No, sir, not all the functions.
That's all. There is a reason I asked you the question, because you must understand the physiology of action of the muscles.
Yes, sir.
Okay, good, well done.
Thank you, sir.
Dr. Manchanda. Dr. Patwardhan is there?
Next is Dr. Saurabh.
Okay, come. No, now is Dr. Manchan.
Good evening.
Time start.
Good evening, everyone. The aim of my presentation is to discuss that anterior and nasal transposition of inferior oblique is an effective way to treat strabismus ursoductorius through different cases. So the history of IO weakening procedures starts from myectomy and recessions, which though is a very strong surgery, still has a postoperative overaction in about 1.7 to 5% of cases. Thereafter, anterior transposition was developed, which did have the complication of anti-evasion syndrome. Keeping that in mind, anterior nasal transmission was developed, which reduced this risk. So ours was a retrospective option study, and the inclusion criteria was all the patients of strabismus ursoductorius with severe inferior oblique overaction who underwent anterior nasal transposition of inferior oblique and had a minimum follow-up of 12 months. The data that was compared pre and post-operatively was motility, torsion, deviation, and inferior oblique overaction. The surgery was done by the silent technique described by Shajar et al., in which the inferior oblique was disinserted and reattached to the sclera 2 mm nasal and 2 mm posterior to the nasal extent of inferioritas insertion. So a total of 13 patients were included. The mean preoperative hypertropia improved from 17 prism diopters to 1.69 prism diopters, and the correction thus achieved was around 15 prism diopters. The torsion reduced from grade 4 to grade 1 with elimination of inferior oblique overaction in all patients, and anti-elevation was induced in just one patient. Just for example, this 25-year-old female presented to us with diplopia in primary gaze, which increased in upgaze. On examination, the Hirschberg test revealed a 15-degree hypertropia in the left eye with severe inferior oblique overaction. We did ANT for her, and postoperatively she was orthotropic and the diplopia had disappeared. So this is a summary of all cases. As discussed before, the deviation reduced from around, the mean reduction in deviation was around 15% diopters, with elimination of inferior oblique in all the cases. So inferior oblique anterior nasal transposition is a relatively new technique which corrects a relatively larger hypertropias as compared to other techniques as per some studies. And with its main advantage being the reduced risk of anti-elevation syndrome. Our study reveals that it can give a mean correction of around 15% diopters. To conclude, long-term results can do indicate that inferior oblique ANT can be effectively used to treat the large hypertropias of strabismus cercoductorius. Thank you.
Dr. Saurabh. सर ये है
So one presentation is last presentation is हाँ कर लो yeah they are still uploading ये नहीं है कहीं और ही डाल दी थी कोई और से yes okay ready okay. Should I start, sir? Yeah. Good evening, everyone. I am Dr. Saurabh Patwadhan, and I will be presenting a study to report non-strabismic binocular vision disorders in a tertiary eye care hospital. Non-strabismic binocular vision dysfunctions, which is an imbalance between convergence and accommodation without evidence of strabismus. It has diverse functions of symptom manifestations. Reports suggest that extended screen time and near work during COVID times has significantly increased the prevalence of NSBVD in large cohort of people. Since our hospital has strong network of referral patients, we decided to study this in our patients who are visiting binocular vision clinic. Aim is to report NSBVD in tertiary eye care hospital in Sangli, Maharashtra to study the association of NSBVD with age, refractive error and its type of anomalies. It's a retrospective study which took place between 2020 and 24. The study population was patient referred to binocular vision clinic with symptoms of eye strain between age group of 10 to 40 years. The sample size of 480 cases. The sampling method was convenience sampling. Study setting was binocular vision clinic. We included all patients having asthenopic symptoms even after full refractive correction who are visiting or referred to BV clinic. We excluded any patients who had history of manifest strabismus, orthoptic surgery, active eye disease, or other eye surgeries. We use mainly the software to assess the binocular vision dysfunction. We use the Siemens basic normative database to find out whether there was any anomalies. Now results show that in our patient group, there were 260 females and 220 males. Out of these 480 patients, 31 had no NSBVD disorders, which was found out by the software. As far as refractive error is concerned, only 33.4% who visited binocular vision clinic were emetropic, while all others had some refractive errors. In the age group, 21 to 30 age group had maximum 43% of the these patients which were recruited. Now, going to types of anomalies which were seen in this particular study, predominantly two types of anomalies were seen. 24% had accommodative insufficiency and 31.5% had convergent insufficiency. But we also saw a few patients having dominant accommodative excess, infacility, accommodative spasm, inertia, and ill-sustained accommodation. Convergence excess, divergent insufficiency, divergence excess, and FVD was also found in few patients. The study observed that large cohort population of 31.5% reported with convergent insufficiency. This probably relates to the fatigue experienced by the ciliary muscles due to extensive near work, which has been already previously reported. This study also showed 24% accommodative insufficiency. So just to remind, this is a patient group of 10 to 40 years and not post 40 years. 7% patient had accommodative infacility, which is there is latency and speed of the accommodative response is reduced. 2.1% also had ill-sustained accommodation. Now there was slight female preponderance. Age group of 20 to 30 years showed higher NSBVD, which was observed in previous studies as well. Association of refractive errors and NSBVD was also significant because 67.08% had refractive errors in this group. Though the management was not studied in the group, these were the few management options which were provided to the patient. Now to conclude, wide range of NSBVD was observed in this geographical context. A prospective study with larger cohort will be necessary to elicit more information and unearth NSBVD severity in this population. Now there were a few limitations, like the treatment of these patients who had NSBVD was not studied in this study group, in this study particularly, and also we did not categorize the severity of NSBVD. Thank you, sir. Yes. Thank you.